Welcome to today's conversation of care, where our providers will discuss the heart of the matter as we continue to bring awareness during American Heart Month to help take charge of our own heart health. I'm Jarrett Stoll. I have the pleasure of serving as Executive Director of Memorial Health Foundation. Our foundation exists to support compassionate, high-quality care across Memorial Health System and to strengthen the health of the communities that we serve. One way we fulfill this mission is by events like today, an educational event. It's been very important to our Board of Trustees for many years that we keep these events free because we know knowledge is power and we want everyone to have access to this type of information. And so because of so many in this room and donors that aren't here, it's how we're able to do this today as part of our mission. Before we move into our program, I want to introduce you to a few people that are with us here in the room, some groups of people. I know we have a few of our board of directors with us who help lead and guide the health system as volunteers, as well as members of our board of trustees who help lead and guide the foundation, the Memorial Health Foundation. I would like, we have board of trustees and board of directors here. You please sing it just to be recognized. Also helping lead our organization and the strategic plan that's put together by our board of directors is our senior leadership team. We have several of those with us today. If you would also please say it in the right moves. You've probably noticed several people in the room on their name badges that have different ribbons, and I want to talk just a minute about what those represent and recognize those individuals. So donors who donate $1,000 or more each year to our Memorial Health Fund is in our Memorial Health Society. And those individuals are represented by wearing the dark blue Health Society or the white ribbons that say Memorial Health Society representing their business or organization. And it's a very important society group of donors to us. It's, again, helping put on events just like today. So if you would please sing to recognize several. As many of you know, we are in a comprehensive campaign to, two, our Together campaign, our Promise campaign, that's helping build the first ever Women's and Children's Hospital in Southeast Ohio on our Belpre campus. And the Promise campaign that's helping to build Sisters Hill General Hospital and Sisters Hill Gender Replacement, SOPI. And those members who have committed to those campaigns $25,000 or more are part of our visionary center. And they are represented here today wearing the orange ribbons or the white ribbons representing their organizations that say Visionary Circle. If you would also please say it to be recognized. And our last society represented here today is the Carl Broughton Society. Many people may recognize that name. Mr. Broughton helped start our foundation in 1981. We wanted to honor his legacy by naming a very special society in his honor. This society are for donors. You have a lifetime giving of $50,000 or more to Memorial Health Foundation. And they are represented with the light blue ribbons or the light ribbons that say Carl Broughton Society. Keep it on so stay be respects. Today's conversation focuses on heart health, an issue that impacts so many of us in this community. And we're grateful to learn directly from our providers and physicians and experts here in the room that help our patients every day. To help guide us through today's program, I'm pleased to introduce Jody Bull. Jody serves as Vice President, Surgical and Cardiac Services and President of Selby and Sisters Hill General Hospitals. You were correct. She's got several responsibilities. President of 2 hospitals and vice president over surgical and cardiac services. A nurse by trade, she began her career at Memorial Health System Flushing more than 25 years ago. She's a proud native of St. Mary's, West Virginia, where she's deeply committed to leading and strengthening the healthcare community that raised her. Please help you up, Jody Bull.
Thank you for that, Jarrett. Yeah, I'm a busy lady for sure. If I'm not here with my team members, I have 2 very busy children, a daughter who's a freshman at Marshall University, and then my son who's a sophomore, who we're right in the thick of wrestling season right now. So does anybody in the room have a wrestler in their family, or have they a son, a grandson? So you know the hangry, sweaty teenage boys. I'm ready for this to be over. Regionals are tomorrow, so we're excited. Yeah, Jarrett did not misspeak. I've been with the health system for 25 years. I always joke that they raised me, and I truly believe that. The interesting part about today with cardiology is that when I started in January of 2001, it was just a few short months after that we opened the first cath lab. We had 2 cardiologists coming from Columbus. They were there just a few days a week to see some inpatients, a few outpatients, and do some diagnostic heart caths. And then fast forward to today, 25 years, it has truly been probably the greatest pleasure of my career in seeing this service line turn into what it has. I truly think it's one of our stars of the health system. We've seen just exponential growth where we have some of the sickest hearts in the country. Today, we are slated to see over 26,000 patients just in our cardiology clinic and nearing 5,000 procedures in our cardiac cath labs. We're now at over 30 providers. We're up to 10 doctors and over 30 providers in our service line. And yes, I have a lot of responsibility, but I have some fabulous people that are really the bones of this service every single day and make it run. And I know a lot of you are here today, and I'm not going to have everyone's name, but there are a few folks that I just want to recognize. If you'll please stand. In the back of the room, we have Tracy Rauch. Tracy is our charge nurse in our cardiac cath lab. She is the master herder of cats. This lady keeps this exceptionally busy lab running with high quality. If you guys are, if you have the pleasure of being a patient, you're most likely going to see Tracy's smiley face. So we couldn't do it without her. Beside of her is Miss Karen Crislip. Karen is the supervisor of our sonography lab. So if you or anyone in your families had an echocardiogram or a vascular study, it's Karen or one of her staff members that have done that. She is truly the best at what she does, and we are so lucky. In a service line that grows 30% every year, those non-diagnostic testing. So she does a fabulous job. Joey Schwartz, who runs the biggest clinic for Memorial Health System, the cardiology clinic, is on a much-deserved cruise right now. So he's missing out on all the fun. So he's not here today. But then we have Ashley Nutter here at the front of the room. So Ashley's the master behind all of this. She really keeps us going every single day. She is the director of all things heart and vascular, from our imaging, our clinic, our cath labs, and our procedures. I also see Miss Allie Keith in the back of the room, Miss Anna Valentine. Allie runs our operating rooms, works closely with our cardiothoracic team. And Anna is the coordinator for our cardiothoracic service line, works closely with Dr. Cousins. I know there are several others. So if you are someone in this room that participates in one of our care teams, whether in our clinic, our cardiac rehab department, our cath lab, anywhere on our inpatient units, would you please stand? Yes, give these folks a round of applause. They've done some fabulous work. So the timeline is interesting. Just to speak of that real quickly, in 2001, opened the first cath lab at Memorial Health System. It was in 2008, I had the privilege of helping lead the team. We participated in a study that gave us the ability to treat heart attack patients in our emergency departments and in our cath labs. That started in 2008. That was part of the Seaport study. It was then in 2012 that we were granted full capabilities by the Ohio Department of Health to take care of those patients at our hospital without open heart surgery on site. It was wildly successful. We built another cath lab. I believe those were completed in 2014. Fast forward a few years, we recognized the need for more advanced cardiac care. As I mentioned earlier, we have some of the worst heart disease in the country here in southeastern Ohio and rural West Virginia. And we saw the need for advanced electrophysiology care. We have bad lung disease, which leads to things like atrial fibrillation and other diseases, and really saw the need to expand our program and start an open heart surgery program. And that program started in 2020. And it was at that time we were able to do more advanced procedures and serve more patients as well. So just to give kind of a timeline for everyone to understand where we started and where we are today. But before I move on, the real star of the show today is Dr. Geoffrey Cousins. Dr. Cousins is our director of cardiothoracic surgery. He specializes in surgical procedures of the heart, lungs, esophagus, and other organs of the chest. Dr. Cousins is also an expert in beating heart surgery, a technique that avoids using a heart-lung bypass machine and can support improved recovery and outcomes. And I can't underline that enough. Our patients after open heart surgery come up to our intensive care unit awake, breathing on their own, and we just have phenomenal outcomes with his talent and expertise. So if everyone can please welcome Dr. Geoffrey Cousins.
Good afternoon. Good afternoon. Everybody asleep already? Holy cow. Thank you all for coming out. I'd like to thank Jody for that introduction, and I'd like to thank the Memorial Health Foundation and Gary Stoll for putting on this event, as well as the board members, the senior leadership, and thank each of you for coming out on this beautiful afternoon, 60 plus degrees in February. You can't ask for anything better. So thank you all very much. I recognize I'm the only thing between you and your weekend, so I will plan to be brief. It's my favorite time to talk after everyone has eaten and are ready to fall asleep. So we will try to be brief here. Today we want to talk about a change of heart, steps to better cardiovascular care. And just a little bit about me. I'm from southern West Virginia in the town of McDowell, which is in McDowell County. We grew up in a coal camp there where my father, a World War II veteran, worked underground coal mining for about 37 years. So you can imagine what his health was like with black lung, heart disease. He had multiple strokes and other issues related to underground coal mining. And my mother was a homemaker and a community activist, and I was their 11th child. And so by the time I came along, their health was already on the decline. Black lung, heart disease. My mother had developed gestational diabetes when she was pregnant with me. We'll talk a little more about that later today, but I was an 11-pound baby. And so from there, I ended up going over to the University of Pennsylvania for undergraduate school and subsequently graduated from the University of Michigan Medical School before doing several years of general surgery and heart surgery between Detroit and the Medical College of Virginia down in Richmond. After that time, I came back to Charleston, West Virginia as a cardiothoracic attending. And since that time, I've operated in every heart surgery program throughout the state of West Virginia, because it's been very exciting, except for one place, which is in Wheeling, West Virginia. And I'm looking for a weekend or something to go up there and do a heart so that I can mark that off of my list. And so since then, we've landed here at Memorial Health System, and there's a lot of excitement going on here locally. The new Athens Medical Campus has been up for more than a year, and they're doing great things in the community out there. And along as well as this program, we're showing our commitment to women's health as well as children's health, and understanding the unique nature that women and children's health bring. And so we're raising a completely new women and children's hospital that will be coming up in Beltry. And as Jody alluded to, we also have a brand new facility coming up in Sistersville, which is going to be huge for that community in terms of access for healthcare. And so other exciting things is that we've had a lot of new physicians on board coming from other parts of the Mid-Ohio Valley to join us at the Memorial Health System. Dr. Peter Filozoff of Obstetrics and Gynecology, he's been here in the Valley for eons. as well as Dr. Heather Strait with her great primary care practice, Dr. Marcella Ruggiel, Dr. Albria Musa, vascular surgeon extraordinaire. Recently, Dr. John Goddard, one of the best interventional cardiologists in the state of West Virginia, now joined us over in Ohio, along with Dr. John Mason, who does general cardiology. Dr. Jason Barton, who has a long-standing practice here, as well as Dr. Joan Allman in primary care. So all these things are very exciting as we continue to ramp up our ability to provide state-of-the-art healthcare for our community. So we focus on cardiovascular disease in women. One of the main things to realize that heart disease is the leading cause of death for women in the United States and in most developed countries around the world. Over 45% of women who are 20 years or older live with cardiovascular disease, and one of the issues is that many of them fail to recognize it as their top health threats. Some of the key risk factors for cardiovascular disease in women include menopause, tobacco use, pregnancy complications, as well as diabetes. Now, most of these deaths are due to coronary artery disease, so I thought it would be important to take a look at the heart and the arteries that supply blood to the heart. And on the left side, you see there a picture of the heart with the vessels, the chambers, and the muscle. If you focus on the other side, though, we break it down and just show the blood vessels, because when we talk about cardiovascular disease, that's what we're talking about. So if you see here in the middle, that's the aorta, the biggest blood vessel in the body. And as soon as the aorta comes out of the heart, it gives the right coronary artery that takes care of what we call the right side of the heart and the inferior aspect of the heart. On the other side, you have what's called the left main. And we call it the main because it gives one down the front that we call the left anterior descending artery, and one that kind of circles around the backside, which we call the circumflex. Now, many of you have also heard of the widowmaker, and it is that left main artery there that we also refer to the widowmaker, because if you develop a significant plaque, or if you close that artery off, then you lose the left anterior descending artery as well as the circumflex artery, and that will often result in a widow. And so if you take a cross section of these vessels and look here, at the top left, this artery is completely normal. It's a three-layered vessel. But over time, due to blood pressure issues, hypertension, high cholesterol, shear stress to the vessel, you see there's a very small tear in the artery wall here. And what your body does to repair these tears, it sends what we call fatty deposits, cholesterol plaques, platelet, and other blood products to try to fill that tear. Well, over time, if you continue to have insult to that area, continued high blood pressure, continued stress, then those areas continue to get thickened, the vessel gets more narrowed, and then you get a blood clot. And if you look at a cross section here or a longitudinal section, you can see how that plaque narrows that artery and decreases the actual blood flow and causes ischemia or lack of oxygen to the muscle beyond those blockages, and people will often get chest pain. Now, some of the specific heart disease risk factors include high blood pressure, and I was very excited to see in the bags that you have at your table that they have added a blood pressure log. Now, it's so very important that you are aware of your numbers, as they say. And blood pressure, oftentimes we call it the silent killer, because until people get a stroke or heart attack or kidney failure, oftentimes they are not aware that they have been walking around with extremely elevated blood pressure. So it's very important that you know your blood pressure. In most recent literature, we started out with blood pressures in the 160s over 95s as kind of the target. And then over the years, that came down to 120 over 80. And now the most recent literature is showing 110 over 70. So it's very important that you know your numbers and that you be in touch with your physician to know what target blood pressure you should be after. Next risk factor here listed is high cholesterol. And we all know that. We're very well aware that statins have been around for many years now to try to help us with cholesterol issue. Next issue there is smoke. And, the evidence about smoking, all of the toxins and things that are in the tobacco products that we use are very deleterious to the heart and vascular system, as well as the lung and pretty much every organ system. So it's extremely important to stop smoking and to seek help. There are lots of opportunities out there for tobacco cessation, including Chantix, nicotine patches, gums, and all types of support systems to help you with most. Now, obesity in this area, particularly throughout West Virginia, obesity was a huge problem. no pun intended. But if you're overweight, you're really at increased risk for heart disease. We'll talk a little bit about that more in a little bit. Along with obesity comes along lack of exercise and a sedentary lifestyle, which truly increases your risk of heart disease 2 to 10-fold, depending on which study you see. Diabetes, in my opinion, I think it's a pandemic or epidemic or whatever you want to call it, but it is completely out of control. We often find people that come to us for heart surgery and they have hemoglobin A1C levels. And the hemoglobin A1C, for those who may not know, is a blood test where we can determine what your sugar have been over the past 3 months or so. And a normal hemoglobin A1C is, we'll say, it's less than 6. We routinely see people with A1C of 16, 17. I think the highest I've seen was about 18.5. Well, those people are really just walking time bombs. If you look at the literature and it says your hemoglobin A1C is greater than 8, you should probably put your heart surgery off because you're at risk for increased major adverse cardiac events. Of course, we know we can't put the heart surgery off when you come in with blockages and a heart attack. So that's an issue that we're often faced with. Stress and depression. I can't stress how important it is to control your levels of stress because, again, your blood pressure is high, you're causing shear stress on your arteries as well as the heart. So it's important to, control the level of stress that you are exposed to. Excessive alcohol use. We often see people who have no blockages in the artery to their heart, but their heart is kind of ballooned up and become what we call cardiomyopathy from excessive alcohol use. So you have to be very careful with your alcohol if you take. Of course, use of street drugs such as cocaine and meth are huge risk factors for heart disease. Now, if you look at some of the unique risk factors in women, pregnancy and menopause, high blood pressure or diabetes during pregnancy raises your future risk. So if you have gestational diabetes or if you have preeclampsia or high blood pressure, those things are very important to get under control and make sure that your physician, your primary care are aware that you had the issues previous to the time you may meet them. Menopause accelerates risk factors. Menopause is a tough situation because all of the risk factors that you had before are exacerbated when you get to menopause. So you have to be very aware of these things and try to get all those other issues resolved before you get menopause because they really accelerate the risk factors for heart disease. One of the issues we run into routinely is small vessel disease. Women are more likely to have issues with tiny damaged heart arteries rather than just the large block. And so if you remember that aortic root, the further you get away from the tree trunk, the smaller the limbs get, smaller the vessels in the heart and the body in general get. And so oftentimes women will have disease in these small arteries rather than just a discrete blockage that we can bypass. And that poses some unique problems. Mental health, stress and depression have a stronger impact on women's heart health. But some of the recent studies I've seen about depression, they're putting depression as a significant risk factor as secondhand smoke, obesity, and diabetes. So that's a real significant thing. I'll tell you, when I have patients who are depressed, clinically depressed, I'm very worried because the recovery is usually complicated. A person who doesn't want to get up to participate with physical therapy because of depression, a person who doesn't want to eat, who doesn't want to have any activity or participate with any of the recovery makes things very difficult. You get constipation from not moving. People develop blood clots and pneumonia from not getting up, walking, or coughing and deep breathing. So depression was a huge issue and needs to be addressed as significantly as the heart disease. And so over the years, many of you may be old enough to remember the Iraqi war and the weapons of mass destruction that we were looking at. And I recently, actually some years ago, I was interviewing a patient and I was asking, well, what kind of work do you do? And his wife chimed in and says, he hadn't done anything in the last 30 years other than lift a fork, a remote control, and light a cigarette. And so as I was looking at that in the data from the casualties from the war, I realized that the weapons of mass destruction that are truly a problem for us are, one, the fork. The fork is a very significant weapon because what you eat is extremely important. And what we find a lot of times is, it's so important that you eat so that your food will be your medication versus getting yourself into a situation where you're taking so much medication you don't have any space for food. And we often have that with people as polypharmacy to the point that they're nauseated and that their eating habits are off. And so you have to be very careful what you put on your fork. A lot of the places that we go, you can load your fork and it's sort of like putting a little IED into your body. It really sets off your cholesterol, your diabetes, the high blood pressure with salt and things along that line. The next weapon of mass destruction, of course, is this cigarette lighter. Of course, what does it do? It gets us to tobacco products. And so it's very important, as we talked about before, that you seek out ways to cut back and also to seek out tobacco cessation. The next weapon of mass destruction is the old remote control. But once we get on to the next one, which is the couch there, and I encourage everybody to, we may not like the Mountaineers, but one thing we may do, some of their fans will, if we burn the couches. If everybody would burn their couch, life would be a lot better because then you wouldn't be sitting down using a remote control, smoking a cigarette, and overhauling on the fork. Right next to that weapon of mass destruction is indeed the cell phone. Again, that is a great source of waste of time, doom scrolling, and typically when you're sitting there scrolling, you're eating, smoking, or watching TV in the background as well. And this is another major, specifically with the social media, and I saw an unfortunate report yesterday that a young child had followed something on social media and called it commit suicide. So this cell phone is a key, well, maybe that's why they call it a cell phone, because you're kind of locked up in your own little mind there, and you get to a situation where depression takes place, and then you have bad outcomes. These other weapons of mass destruction there are DoorDash, Grubhub, and Amazon, because all of these things enhance your sedentary lifestyle, keep you from getting up, moving, exercising, and doing those things, which we all know decrease heart disease. And I see Amazon, we're all using it quite a bit, because yesterday they said Amazon has surpassed Walmart as the biggest company in the world. So everybody's using Amazon. So do you know the warning signs of a heart attack? That's very important. Some key symptoms and warning signs. While chest pain is common, and this chest pain the patient described to me as suffocating chest pain, feels like an elephant sitting on my chest. But women oftentimes will not experience chest pain at all. They may just have unusual fatigue with unexplained exhaustion. They may have pain in areas such as the neck, the jaw, upper back, the shoulder, or the abdomen. Respiratory issues, including shortness of breath. One of the very common things that I see in a lot of our ladies is digestive discomfort. So they'll be nauseated, they'll have some vomiting or severe indigestion, and they don't often come to the hospital, to the emergency room to seek help. If after it comes, they realize the Tums aren't going to work for it. Other signs include dizziness, lightheadedness, or sudden cold sweats. And what's very interesting is that 43% of women who had a heart attack had no acute chest pain symptoms. That's why it's very important for you to be attuned to yourself and not ignore any changes. So I'll introduce you to one of my former patients, who was a 76-year-old lady who came to the emergency department with epigastric pain. She actually denied having any chest pains, and she reported unusual fatigue and nausea, but she had no vomiting. She had a past medical history of diabetes, and actually her A1C was 12.5, so uncontrolled. Obesity, her blood pressure was 172/101 when she arrived. Her cholesterol was elevated. She was also severely depressed. She'd had a heart attack in the past as well as a stroke, and she had stents in her heart. And she's been smoking 2 packs a day since she was 14, so she had really severe COPD. Her medication is called Carafate, Plavix, Tums, Januvia, and Singulair for her COPD. Of note, she lived alone. She had no hobbies, and she only drove occasionally. Her labs, chest X-ray and EKG came back. She was having an acute MI. So she was taken to the cath lab, and indeed she had disease in all of her vessels. And so, as her being diabetic as well, she had an opportunity to meet the heart surgery team. And indeed, heart surgery is a team sport. It is comprised of a lot of different folks. Anesthesiologists, scrub techs and nurses, circulators, physician assistants, as well as nurse practitioners, perfusionists, cardiologists, the assistants, the open heart nurses, respiratory, physical, and occupational therapists, housekeepers, the blood bank in the lab, as well as social workers, radiology, and people from the administration. And the two people I left off the team was one, the surgeon. I didn't put it. And then the patient care techs who help us out tremendously with patients there. And I see a significant part of my team back there in the corner, wave guys. That's the whole OR team there. And then we have people in the cardiology office. Jody had acknowledged these people, but they play such a big role. Carrie, I couldn't live without Carrie. She's my nurse, makes sure that I am where I need to be, when I need to be. And so it's very important. Here are some of the procedures that we've performed. We do pretty much everything adult cardiac minus heart transplant. And so accessing the heart, contrary to popular beliefs, the best way to a man or woman's heart is still through the chest, not through the stomach like some people think. And this midline incision is extremely well tolerated. And so that's one of the first things I find out when I go to visit people and we tell them, they say, oh, they said you're going to crack my chest open. No, we don't crack my chest open. We do a very controlled incision. And most of my patients who are, average, say 65, they don't take pain pills after the surgery. I have guys come in routinely, and Carrie can attest, we give everybody 30 pain pills when they leave, and they come to see me in a month. And the routine is, Doc, I didn't take any pain meds since I left the hospital. They actually complain a little bit more of the leg incision than they do the chest incision, just to give you an idea. So we make a very controlled incisions. We then have access to your heart. We've had our cardiac cath, so we have our roadmap of what we need to do. At this point, we make a decision as to whether we're going to do your surgery with your heart beating or whether we're going to put you on the heart-lung machine. And pictured there, the heart-lung machine, which is a pretty big beast. To use the machine, we have to put cannula in your aorta as well as the right atrium. Some people from what we call pump head, meaning post-perfusion syndrome or some subtle memory loss. Other risk factors when you're putting people on pump include stroke, kidney failure, lung failure, bleeding, because you have to use a large dose of a blood thinner called heparin to keep the machine from clotting. And then there's the systemic inflammatory response that takes place when you put these cannulas in. And that's what it kind of looks like after we get you all set up with all the cannula in place. And then once these things are in place, we can start the surgery. The other option is to use these two little devices here. One the suction cup and one the stabilizer. And we can then do the surgery with the heart beating continuously, or what we call off pump. And around the country, about 8% of the surgery for cavities are performed off pump. It's much less invasive. We don't have to use as much heparin, so we have much less blood loss, leading to less transfusions. There's a decreased stroke and renal failure rate. There's less post-operative atrial fibrillation. And all this translates into decreased length of stay. A lot of our patients are able to get out of the hospital in 2 days. So that definitely cuts down on the cost. And one of the biggest things, and the reason that I went through during the beating part surgery, is because you get better outcomes in high-risk patients and women. Women traditionally have not done as well with heart surgery as men. But when you do the surgery with the heart beating continuously, then the results for women begin to approach both. People with calcified aorta, renal disease, cerebral vascular disease, and other bleeding disorders are also a great candidate for off-pump surgery. And here you can see the suction device holding the heart in place, and then our stabilizers that sit around the artery that we're going to work on, keep it relatively still while the rest of the heart we're able to perform the surgery. One of the other great things is that back in the day when I came along, we used to get the saphenous vein out of the leg, we used to just kind of lay a knife up near the thigh and run it down to the ankle. And that was quite a problem for people, particularly for diabetics, when we use below the knee. And so now we have what we call endoscopic conduit harvest. And if you can see in the left picture there, there's an incision that's about 2 centimeters. And using the scope, we're able to get the vein out, this very small incision, without laying the leg over. And that's a big deal because people can get up earlier, there's less pain, less bleeding, and they're able to get back to their activity quicker. Another great innovation is what we call a fart stream. On the right side, you see I've got a clamp, and this is on the ascending aorta. And I have to clamp that aorta to put a hole in it so that I can attack the vein graft and provide blood flow for it. Nowadays, we can just use this little device here. We don't have to clamp. We punch this little umbrella unfolds. We can do our mask motions and then remove the umbrella, whatever, without having to feed a aorta. And that has reduced the stroke rates down to less than 1%. So that's very exciting. So our outcomes from CABG, mortality is about 1 to 2%, stroke and renal failure about 1%, meatus stenitis or infection in the sternum less than 1%. And these graphs, the arteries that we use from under the chest wall, what we call the lima, after 10 years, 80 to 90% of those are still doing well. The veins we use from the leg after 10 years, about 80% of those are still doing well. But that all has to do with each individual patient. And did they stop smoking? Did they get their diabetes under control? Did they get cholesterol under control? Did they get off the couch, drop the cigarette lighter, and pay attention to what they were loading on the fork? If those things happen, then you can get these types of results. Now, there's about 4 things you can do to help reduce the risk of your heart disease by about 82%. And we talked about this. Don't smoke. If you smoke, you're 2 to 6 times more likely to suffer a heart attack than a non-smoker, and the risk increases with the number of cigarettes you smoke each day. I had one guy who was a 4-pack a day since he was in his teens, and we gave him some Chantix, and he was able to stop. So that's a good thing. Keep a healthy weight. The more overweight you are, the higher your risk for heart disease. Eat right. Vegetables, fruits, lean meats, white meat, fish. You want to bake or grill. You want to stay away from fried foods and foods that are sold in plastic or boxes. You want to kind of focus on eating things that grow from the earth instead of highly processed meat. And again, be physically active. Heart disease is almost twice as likely to develop in inactive people. So I encourage you to get up, get your steps in, take control over your heart care, meet with your primary care physician and cardiologist, and keep in mind we're here if you need us. Thank you very much.
All right. Thank you, Dr. Cousins. Interesting presentation for sure. So at this point in time, we're going to introduce our other cardiologists and physicians in the room. Doctors, you should have a mic at your table you can clip on and use. Yep, right there, close. We're going to ask the audience for any questions. We have these brilliant physicians here. Please take advantage of this. We want to hear your questions and let them help us respond. So with us today, before I get into the details, I just want to say that the team of clinicians that we have at Memorial Health System today, I would put up against anyone in this country. They have truly seeing it evolve over the last 25 years, truly elevated this program. We have some wonderful talent, and you all are in great hands. So first off with us today, and if you'll please stand, we have Dr. Jason Shaw. Dr. Shaw is the director of our cardiology program. And before I get into some of the other details, the most important part is he was born and raised right down the road, or up the road in Caldwell, Ohio, coming back to take care of this awesome community. Dr. Shaw is an interventional cardiologist specializing in structural heart care. Dr. Shaw diagnoses and treats heart conditions using minimally invasive catheter-based procedures. This subspecialty combines advanced imaging and precise techniques to restore heart function and improve outcomes. All right, next up, we have Dr. Goddard. Dr. Goddard, if you'll stand. So Dr. Goddard, long-standing, well-respected cardiologist, interventional cardiologist here in the community. We are so very lucky. He came over to join our team and take care of patients in Marietta. So Dr. Goddard is an interventional cardiologist. He specializes in diagnosing and treating heart conditions using minimally invasive catheter-based procedures. This subspecialty combines advanced imaging and precise techniques to restore heart function and improve outcomes. We also have with us today Dr. John Mason. Dr. Mason, another long-standing general cardiologist out of Parkersburg, came over to join us. We're extremely fortunate, brought a lot of patients with them. Just doing a fabulous job. As a general cardiologist, Dr. Mason specializes in diagnosing and treating conditions of the heart and blood vessels. He cares for patients with a wide range of cardiovascular concerns and helps them manage risk factors while creating personalized care plans to prevent future heart problems. And I believe that's who we have. Unfortunately, Dr. Musa, I don't believe Dr. Jones, if she snuck in. I did not see her. Okay. So what we're going to do at this time, we want to open it up to the floor. and let our cardiologist answer some of your questions. Anyone have anything? I want to ask these gentlemen.
I was just wanting to know about the Watchman procedure and if it's done at Marietta Memorial and how successful it is.
Great question. Can you hear me okay? So yes, the Watchman procedure is done at Marietta Memorial. Watchman is a brand or a maker of a percutaneous left atrial appendage closure, which is a way, in the setting of atrial fibrillation, 90% of strokes occur from clots that form in this little embryonic outpouching in the top left chamber of the heart. It's a place that blood likes to stagnate, and blood that's stagnant likes to clot like jello. And so we eventually try to put you on blood thinners to prevent a clot from forming to mitigate your stroke risk. However, a lot of times people can't be on long-term blood thinner for various reasons, whether they have easy GI bleeding, or they have falls, or they have occupation that puts them at higher risk for bleeding. And so in those situations, a Watchman procedure is as good as a blood thinner preventing stroke. What it is a glorified plug that we plug this outpouching, we let the heart grow over it. It takes about 6 months to grow over. And then after that, you're just on a baby aspirin once a day, lifelong. During that 6-month period, we've got you on a couple medications, aspirin and another medication that thins the blood a bit to prevent clot to form on the device while it's growing over. But the procedure itself is exceedingly successful. The complication rate is 0.5% or less. We've been doing it for a couple of years, at least three plus years now. We've got a great team. We've got Katie, we've got Jess, and Bev is not here, but we've got a great team for our Washington program. Great question.
Great question. We did have Dr. Jones join us in the room. Dr. Jones take care of patients. So that is Dr. Jennifer Jones, one of our general cardiologists on our team. So, Dr. Jones, you can jump in at any point in time to answer questions. Any other questions from the room?
I would just like to add a little bit about that. Dr. Schott, or they said, is an interventional cardiologist. And obviously I do surgery. So he treats, you have AFib and you don't need surgery. He treats you percutaneous through the groin. If you do need surgery and you've had a history of AFib, I can also treat the AFib in the OR with what we call an AtriClip. So he plugs it from the inside and keeps anything from getting out. I clip it from the outside to keep anything from getting out. So if you need it that way, we can do it as well. Thanks.
Any other question here?
With a rapid rise in GLP-1 drugs, just wondered how those affect heart health.
It's a great, very pertinent topic. So GLP-1 inhibitors. The most data is with people that have coronary artery disease and diabetes. There's some data that would suggest that it's beneficial in people with coronary artery disease alone without diabetes. However, the benefit there is not as robust. They tout a 20% relative risk reduction, but the absolute number is about 1% or less in major adverse cardiac events. So most of the data lies with if you have diabetes and you have coronary artery disease. That's where your big bang for the buck is. Outside of coronary artery disease, there's also benefit in heart failure. So the real main mechanism, it's kind of a way to keep in heart failure, keep your tank from going too dry but not overflowing. So if glucose follows, if it exits through the urine when it's too high, water can follow it. So if you're walking down the hall with a metal pail, bucket, and you don't want to overflow too much, but you want it to be full, it's a way to keep it from the volume for being overwhelming, but not make it dry. So, anything anybody wants to add?
And we had a question, was it you, Mayor? What, if any, is there hereditary factors involved in heart disease?
Yes, there is a significant genetic component to coronary artery disease. We often see patients, particularly patients who have both a mother and father who have coronary disease. They'll present very early in their 30s and 40s. So there's definitely a significant genetic component. And if you have family members who have coronary artery disease, then you need to start focusing on those risk factors very early. Take care of any diabetes, get your weight under control, stop tobacco use, get your cholesterol things, because the genes are, you can't hide from them, but you can try to slow down the process.
Okay. Yes, ma'am.
So, I've been hearing a lot about a calcium test. I don't know if that's just where my parents are in their lives. So I was wondering to know more about that, and maybe for somebody that's a woman, 40 plus, generally healthy, but maybe has heart disease in their family, how important that is for someone like me to get that now as a baseline.
Thank you. I'm a big fan of the calcium score test, which we offer here in Marietta. It's about $100 or so, which is primarily a service that's offered. It's not a moneymaker for anybody, but it can be a great test for a screening tool. So if you're having symptoms, it's never the right answer. It's not good for telling if a certain problem is due to atherosclerosis, even though that can be a tempting way to think of it sometimes. If you have a calcium score of 0, you still can have coronary problems, acute coronary syndromes, and heart attacks, but though the chances are low. That really isn't good for somebody with symptoms. For someone in their 40s, 50s, 60s without symptoms, it can be a great test. And what it allows us to do is identify atherosclerosis before it's clinical. Okay, so looking for subclinical disease. And it really allows you to treat somebody who you otherwise might not treat aggressively, especially, much years before their first event, and hope to put that event off for the foreseeable future. So oftentimes I'll see people in the office who come in for various risk factors, various abnormal tests. Oftentimes they're younger people, but they certainly have a lot of risk. Just living in the area has a little bit of risk, it feels like. And, it allows you to look at people's lipids from a different point of view. It can be a kick in the pants, getting you off the seat. I love Jeff's weapons of mass destruction slide. The phone in particular is a killer, it seems like sometimes. I have mine right there too, though. I can't say much about it. And for a smoker, or for somebody who's overweight, sleep apnea, all these things that you don't want to, you're hesitant to treat. It's hard to get the motivation to get on it. It can really be helpful to hit you in the pants a little bit. And it gives you a much better idea of how aggressive to treat somebody, defining treatment goals, etc. I've had a calcium score, my wife's had a calcium score. It can be reassuring, which can maybe too much sometimes, but yeah, it's a great test for a lot of us younger people that are trying to determine your risk and help treat those risk factors. Okay, absolutely.
Thank you, Dr. Goddard. Can your primary care order that?
Yes.
Yes. Okay. Other questions? Sir?
I'm in the hardwood lumber business. I can never do what these doctors do. And I was wondering, it seems like you hear much about AFib anymore, a lot more than what you did, like I did earlier in life. I'm just curious if COVID had something to do with it and the vaccines.
Yeah, it's a Great point. I think that the AFib burden in the community is probably more prevalent because our detection is better. We've developed a lot of ways to monitor for AFib, and the awareness is higher. So, for example, this was probably 5 years ago. They put out the Apple Heart study, where they put it on your Apple Watch if you've got one of those smart watches, where it can actually detect AFib or heart rates go up, and you can even analyze your EKG right there on your watch. And it actually affected 32% of outcomes in that study. Likewise, there's this thing called AliveCore or Cardia, which is an app on your phone where they'll send you this little paddle, and you put your fingers on the paddle, and it'll connect this electrical circuit and put a 30-second readout of your EKG, and it'll try to interpret it. You can store, text, and email it. But it's this access to these devices that we're now recognizing what it is, detecting it. But that's probably the most prominent reason why the burden is increasing. And obviously, risk factors for AFib, obesity, versus, 100 years ago, there's certainly a difference. Longevity, we're living longer, so, that also increases your risk factor for AFib is age. COVID certainly had its unexpected, consequences. I would say that much more prevalent was myocarditis from COVID rather than the vaccine itself, although it wasn't zero. But we're talking a couple decimal points difference between the prevalence of myocarditis and from the actual infection rather than the vaccine. I remember my brother called me up and said, "Hey, should I get my kids vaccinated?" At that time, and he ran the data, and the chances of myocarditis from COVID was much higher, like 10-fold higher than the chances of getting myocarditis from the vaccine. So, although nothing in the world is 0%, the benefit exceeded the risk at that point in time. I wish it was 100%, 0%, but can't say zero.
We have a question here.
Yes, my husband's just 6 months out of cardiac triple bypass surgery, and he went through cardiac rehab really well, and he walks every day. But by the time evening comes and he gets in a shower, he takes really long showers. He said when he's got his hands up doing his hair and all this, when he goes out, his shoulders and his neck is hurting, and he has to lay down for about half an hour to get his strength back. So my question is, should we be worried about that?
No, I don't think so. I think he's just healing up. How long was the surgery? 6 months. He's still healing up. As long as he continues to improve, I don't think there's anything to worry about. He may still be a little sore from the movements that he's doing, but keep going, do cardiac rehab, and as long as things continue to get better, I wouldn't worry much about it. If he gets worsening pain, give us a call.
We've heard about high blood pressure. I just wondered what you consider to be a risky low blood pressure. How low is low?
Some of that'll have to do with if your symptoms, if you have symptoms or not. I have some patients whose blood pressure is 90/40. They're perfectly fine and they don't have any symptoms. It's out of treating. But if you're short of breath or lightheaded, or when you stand up you get dizzy or feel fainting, then it's probably too low. You may be on too much medication. That would be the first place I would start. Additionally, if you're running low, I would be concerned whether or not you're dehydrated. But if you're taking in adequate volume and things along that line, I would look at my medication list, and then failing that, if you're symptomatic when you're low, I would meet with your physician.
Does normal or appropriate blood pressure vary with age?
I got that. We'll try to. Can you hear me? This is maybe about the last couple of questions, but yes. blood pressure goals do vary with age somewhat, and we get a little bit more permissive with blood pressure as we get a little older because, I always cringe a little bit when I hear the real aggressive goals that Dr. Cousins mentioned during his talk, because when you strive for those real low numbers of older folks, you're really going to start to see some problems if we're not careful. So I think it really is very useful for people to take a very active role in their own care and their monitoring, which we don't like to do. But these days, you really have to take advantage of the available technology. You can get a blood pressure cuff at the pharmacy for $50 or something like that.
We've had them out in our office when you visit us.
Okay. We don't do that. But checking your blood pressure for AFib. So that can be the first clue, is these home monitors for your blood pressure. And then also, like if a patient brings the cuff into the office as well, I can validate it. Nothing worse than bad information. So, a cuff that you have may work well for you and poorly for your wife and vice versa. So it's always nice if the patient tells me they have these numbers and they had it at their regular doctor's office and they validated the numbers and the blood pressure cuffs. I feel much better about that information. And I think it's really important to take home. We need to be involved in our care. I mentioned knowing our numbers. These days, it's almost irresponsible to not follow your blood pressure. And if you have heart disease, you need to follow your heart rhythm in some way. It's there, it's easy, it's accurate, and the Apple Watch, I don't have any Apple stock that I'm aware of, but the Apple Watch, I think the other brands can do a similar job, though I haven't seen it as much, and mine's an Apple, so I'm used to it. It gives you an EKG quality tracing done well, and you can take that with you to your doctor, to your visit. I have patients who print off pages of tracings. You can take it, goes to your phone, you can print that off and bring it in. It's almost a diagnostic tool. I mean, it's very useful. So I just encourage folks to be actively involved in their monitoring, watching your blood pressure, watching your heart rhythm, and just a great tool to take advantage of. I may have gotten off track there, I'm not sure.
All right, thank you very much. We have one more question in the very back. We'll do one final one.
I'm asking for somebody else. I'm thinking about vaping and cardiac disease.
She's asking about vaping and cardiac disease.
Yeah, same as cigarettes. Quit. The problem with all of these things is that, years ago when they were after the big tobacco companies, they never really revealed what's actually in them. But there's some really toxic stuff in them and very addictive stuff that cause you to light one with the other one before it. Vaping is the same. We really don't know what's in them. And there's a lot of potential, contaminants or toxins in them. And so I would recommend that you stop vaping, try to do the same thing that you tobacco cessation, and give it up.
All right. Thank you very much. I want to thank all of our providers and physicians that are here today that presented and answered questions. They will be around for a few minutes if you have some other questions that you'd like to talk to them about afterwards. And Dr. Cousins, I always appreciate looking around the room when you get ready to talk about filleting the leg open because of the reactions that we get every time you say that. So appreciate that. And I also got a text from our legal counsel that I need to share that we are not advocating that you burn your couches. We wanted to make sure that that is not a memorial health message that we're putting out there. But again, want to thank you for coming out and attending. If you've enjoyed this, we have our next Conversations of Care on May 19th. That will be right here, and we'll focus on primary care and featuring primary care physicians and providers here in Wood County and throughout West Virginia. That will be here. Also, coming up is our 21st fashion show, and that supports our cancer patients. All the models at that fashion show are either survivors or currently going through their cancer journey. We have with us today Susie Casto, who started the very first fashion show. It's been going on for 21 years. It's a huge benefit to our community where all funds stay local, and that's April 10th. Tickets are on sale and they sell out every year. So if that's something you're interested in, we hope that you will purchase tickets soon. And you've seen some people with I'm a Grateful Patient, our gratitude program. If you or someone that you know has been touched by from care throughout our health system anywhere, we would love to hear your story. We know that gratitude does so much for us when we're able to express it as part of our own healing, but it also does a lot for our team when they hear how touched that you are. And so you have cards on your table about that as well. And so we would love to hear your story if you've had an experience at any time throughout our health system. Again, thank you for being here. I hope all of you've enjoyed, and I hope you have a great weekend. Thank you.